Corridor care, as we've heard, is one of the clearest signs of wider pressures across urgent and emergency care services, including rising demand, delayed discharge and constrained hospital capacity. In my remarks today, as so much has already been said, I just want to focus on a couple of areas. As the MP for a coastal community, I would like to make it very clear to the Minister that when we are looking at these pressures, there are additional pressures facing specific communities. And coastal communities tend to have older populations, poorer health outcomes, and Worthing West does sit within one of England's coastal communities. And I can say to the House today that their population is older than average, even though I'm not older than average. Frailty is increasing, multiple long-term conditions are common, emergency admissions are correspondingly higher, recruitment is harder in coastal communities, and deprivation does exist alongside affluence. All these things contribute to the pressures that we have discussed this afternoon. We have University Hospital Sussex in my constituency of Worthing West, and as we have discussed, NHS England's data is not completely useful in many instances, but it is the best that we've got. So I have had a look, and for University Hospital Sussex, we have 4 emergency departments, and across those 4 emergency departments, they are seeing on average each day 65 patients in their emergency department corridor care service, 65 patients each day. And in their general and acute ward, they have corridor care for 39 patients each day. That is not insubstantial. We need to think about, we've talked about the back door, and I really want to talk about the front door. You'd be unsurprised to hear that as a public health doctor, I want to say that prevention is a corridor care policy. And that government needs to ensure investment in prevention and public health is recognised as part of the solution to reducing corridor care. We have got to reduce the flow of avoidable illness into our hospitals in the first place. And that means tackling smoking, poor housing, air pollution, obesity, loneliness, poverty, and delayed access to community care. Corridor care begins long before a patient reaches accident and emergency.
Will she give way on that point?
I will.
Thank you. Thank you. And I very much thank my honourable friend for giving way. My local hospital, Basildon, is in one of the 40th worst trusts for delivering hospital care. And in regards to what she was just saying there, will she agree with me that not having the right community equipment, community disability aids, and also adaptations to homes can quite often be a leading cause of discharge? And will she delay discharge? And will she urge the Minister to look at this when they commit to ending corridor care by the end of this Parliament?
I thank my honourable friend for those excellent remarks, and I absolutely agree with her wholeheartedly. So, as I've said, corridor care is a symptom, and our challenge is to identify the underlying causes rather than simply measuring the symptoms. It is what happens when demand, delayed discharge, workforce shortages, social care pressures and preventable ill health collide in one place. Stakeholders that I speak to, and I'm sure colleagues across the House speak to, repeatedly call for public health investment, stronger community services, social care capacity and prevention of avoidable admissions. Every prevented stroke, every smoking cessation intervention, every warm home, every child who grows up healthier, every patient supported early in the community is one less avoidable admission into an already overcrowded emergency department such as my honourable friends in Tooting Bec.